want the refractory period of my AV node to be such that my ventricle can get all those impulses, right? So the refractory period of the AV node will depend on sympathetic and vagal influences. Every circuit has an intrinsic refractory period. Every structure has an intrinsic refractory period. But how many beats the AV node will allow through per minute simply depends on its refractory period intrinsically and as modified by sympathetic and vagal tone. Yes? So usually, if I'm sitting and resting, the AV node will allow somewhere around 150 beats through. So if I am walking here, I'm a happy guy, and all of a sudden I develop atrial flutter. My atrial rate is 300. My AV node says my intrinsic refractory period is such that it will allow 150 beats through. Every other beat will get through, right? So what will that look like on an electrocardiogram? I will have this P wave getting through, this P wave not. This P wave getting through, this P wave not. This P wave getting through. It's called atrial flutter with 2-to-1 AV block. And the AV node, the purpose of the AV node is to impose that kind of filtering. Yes? Well, I'm going to feel a heck of a lot better with a ventricular rate of 150 than if I didn't have an AV node and my ventricle were going 300 times a minute. Then it would have no time to fill and I would have no cardiac output. But do you think that I am going to feel well if out of nowhere my ventricle starts going 150 beats a minute? No, it's not going to have, what symptoms might I have and why? My cardiac output will fall, right, because my ventricle doesn't have enough time to fill, so I'll get dizzy and lightheaded and faint. And my atrium doesn't have enough time to decompress into my ventricle. So I will get, on the left side, I'll get pulmonary congestion, right? So what are my options in treating that patient? You see on an electrocardiogram a P wave rate of 300. You say, okay, I know that that defines re-entry within an atrium. And I see a ventricular rate of 2-to-1 block of 150. Just in broad terms, what are my options for treatment? I can use a drug to terminate AV nodal to terminate intraatrial reentry, right? Right, I can stop the arrhythmia. Then I need to choose a drug that acts on atrial tissue. What's my other option?
Back the AV node.
Right. So just to elaborate on that a little bit, I could use a drug that would increase the refractory period of the AV node, or block conduction through the AV node, right? Those are my two options. Right? What are my options to treat my arrhythmia? AV nodal reentry. Well, I'm going to need different drugs because now I'm not looking, if I see a P wave rate of 150 to 250, I know that's not intraatrial reentry. That's AV nodal reentry. I would need a drug if I want to block that circuit that acts on AV nodal tissue, not atrial tissue, right? If I see a patient in ventricular tachycardia and I need to terminate it, I need to use a drug that acts on ventricular tissue, right? So for atrial arrhythmias, atrial flutter or atrial fibrillation, I have two choices of treatment. I can use a drug that acts on atrial muscle to stop the rhythm, or I can use a drug that acts on the AV node to enhance its filtering properties. Right? For AV node reentry, I need to block it, so I need something that blocks the circuit in the AV node. For ventricular tachycardia, I need something that blocks the circuit in the ventricle. That all make sense? Sure? What's not clear? Tell me.
I guess I'm just confused about the part when you were saying like the QA goes 300.
Yes?
And then you're getting, that means you're having reentry within the atrium.
Right.
So you're going to use a block, or I'm sorry, a drug to terminate the AV node entry. And then
So if I have a P-wave rate of 300, that tells me that my rhythm is coming from a structure where reentry generates a rate of 300. That happens to be the atrium, right? Then I say, okay, my atrium's going 300 times a minute. My AV node is filtering every other beat and letting my ventricle beat at 150. I don't feel great if my heart is going 150 beats a minute. My choice is stop the rhythm by using a drug that acts on atrial tissue, or simply use a drug that acts on the AV node to increase its filter. So instead of 2-to-1 block, I would have 4-to-1 block. Then my ventricular rate would be 75. Yes? So for intra-atrial arrhythmias, I have two choices of treatment. Stop the rhythm or enhance the filter of the AV node. Yes?
If you enhance the filter of the AV node, you're not really fixing the atrial flutter, right?
I am not fixing the atrial flutter, but all that we really know, the symptoms primarily come from what the ventricle is doing. You're absolutely right. It's not perfect. A perfect strategy would be to get rid of the circuit. But another strategy, we will talk in a moment, that the drugs you need to act on muscle, atria or ventricle, have potential toxicities. But you're right conceptually. Ideally, I'd get rid of that rhythm. It turns out that the drugs that enhance the filter of the AV node are pretty harmless drugs. We'll get into those. But you're right. As a strategy, if I use an intra-atrial drug to block it, that's perfect. But you can understand why an acceptable alternative would be to simply let the ventricular rate be 75 instead of 150. I would feel much better. Yeah? Yes?
So that treatment option is one of the problems with the atrial flutter being so fast and have all the blood out, so then you get pulmonary congestion.
The real problem with atrial arrhythmias is not so much that I lose the atrial integrity or atrial transport. The real problem is the rapidity of the ventricular response. If I get rid of your atrium and I just let your ventricle beat 75 beats a minute, you'll feel fine. The atrium has a little bit of an enhancing function, and at the end of diastole, kicking blood in, it contributes maybe 20% of cardiac output. So in people who really need that, have very weak hearts or very stiff hearts, atrial transport's important. But in most people, it's really what the ventricle is doing that's important. Yes, sir?
So the SA node has no bearing on the
What?
atrial.
The SA node?
Yeah, so as far as starting the arrhythmia or even blocking the SA node.
Once I start a circuit, that circuit overrides the circuit in the atrium is 300 times a minute. If I have a sinus node that's going 60 or 70, the sinus node might fire, but it's not going to be the atrium is going to be responding to this thing going 300 beats a minute, not the thing going 60. It's just going to override the sinus node.
I just figured they're still interconnected, so there might be some sort of effect there.
That's good. The sinus node becomes irrelevant when I have something beating faster. right? In the way the conduction system works is there's a hierarchy of pacemakers, right? Why does your impulse start at the sinus node? Because your intrinsic phase 4 depolarization is faster at the sinus node than anywhere else, right? And there's a hierarchy of pacemakers. So once something takes over, then the sinus node might still fire, but it doesn't govern the atrium. Yeah? Yes?
In terms of ventricular fibrillation,
Uh-huh.
especially, I guess,
Uh-huh.
If it goes 150 or 200,
Ventricular tachycardia,
right?
150 to 250. Uh-huh.
How does that work in terms of like depolarization? It doesn't have to do that; it's a constant get repolarization, constant depolarize.
So it will depolarize, and then after a certain amount of time, it will repolarize. In other words,
Will we still see those waves even though it's happening so quickly?
you will see on an electrocardiogram, you will see each time the ventricle depolarizes, you will see it. Yes? Yes?
So you're saying for some of these arrhythmias, they'll just come on, and like the AV nodal one will just come on and go off on its own. How does it stop on its own?
Very good question. Wonderful question. How do rhythms stop on their own? So let us say that for me, okay, when I get my tachycardia, it goes on for about 2 hours. So why is that? If I do nothing about it. And we'll talk about what I can do. But so my circuit goes 190 beats a minute. Let us say my refractory period of my AV node is 195. In other words, the conduction velocity is making it go 190, and the refractory period, the number of times the cells can fire, is 195. So as long as my rate is 194 or below, the circuit can keep going. Anything that makes the conduction velocity faster than the refractory period, the circuit's over. Right? That make sense? So the reason my circuit breaks is because my cardiac output goes down when I'm in the arrhythmia. What happens to my sympathetic tone in response to a fall in cardiac output? Goes up. What happens to the velocity of the circuit? It increases. So when it's after 20 minutes, my circuit's 191. After 40 minutes, it's 193. After 2 hours, it's 194. Once it reaches 195, that's the refractory period of the circuit. Boom, circuit's over. Yeah? So let's talk about other things that can influence that. It's a very good question. Yes, sir.
Can you then artificially try to break out of that by
Wonderful question. Can I artificially, how do you think I might try to break out of it?
run faster?
So one option would be to increase the velocity, the conduction velocity, so I get the other option, which is easier, is what can I do to prolong the refractory period of my circuit? What can I do, in contrast to atrium and ventricle, what's the gig with sinus and AV nodes? Are they richly or poorly innervated by sympathetic and vagal tone? Richly, right? So what would I want to do to prolong refractory periods?
Prolong, I'm not sure.
You got it. I'd like to prolong the refractory period of the AV node, right? Right? How do I do that? What would vagal tone do to the refractory periods? Sympathetic tone shortens everything, right? Enhanced sympathetic tone. I want the refractory periods to be very short because I want to be able to escape from a threat. So I want the cells to be able to recover excitability right away, right? What does vagal tone do? It prolongs refractory periods. How can I enhance vagal tone? Carotid sinus massage, you got it. So what I do actually to break my circuit, if I do nothing else, it goes 2 hours. I stop, I do one of two things. I do carotid sinus pressure, that enhances vagal tone, prolongs the refractory period of the AV node, and my circuit can stop. There is a maneuver that people do called Valsalva's maneuver also, where you can stop and just bear down hard, that increases intrapleural pressure. There are a lot of vagal receptors in the pleura that can also break the circuit. But conceptually, that's a very, yes.
Could you also break the circuit by increasing sympathetic tone past that?
I could break the circuit by increasing the rate faster than the refractory period, yes.
Is this just for AV?
So, good question. It is just for AV because the atrium and the ventricle don't have much vagal tone. Okay, so, all right. So, let's talk about how we might break these circuits. So, let us say I have a circuit, right? I have an A and a B, and the circuit's going around. What are my two options for blocking a circuit? I can either block conduction right? That's pretty intuitive. I block conduction, there's no conduction. Second is I can prolong refractory periods. Right? Just like I prolong the refractory period, the circuit tries to come around. If it encounters refractory tissue, circuit's over. And so we're going to talk now about antiarrhythmic drugs, but that's going to be a very important principle because that's all a drug can do. Can do those two things. To block conduction or to prolong a refractory period. Right? You're right in what you say about, yes, if I could make the circuit go faster, I might then make the velocity exceed the rate, but that's hard to do, and a drug certainly can't do it. So really all a drug can do is it can block conduction or it can prolong a refractory period, right? And so we're going to have to ask, okay, what governs conduction and refractory periods in atrium, AV node, and ventricle? And what drugs can do this in each chamber? It turns out that atria and ventricle, muscle, are both the same, so that's good. You only have to learn about muscle, and AV nodes are good. So let's talk. Yes?
I'm a little confused. Once you break the circuit,
Yes.
you'd assume that the heterogeneity is still there. So
It is, but I don't have the inciting premature beat to take advantage of the heterogeneity. So, I mean, the heterogeneity was there the minute before the circuit started too, but it required the premature beat to come at just the right time, right? It also requires, remember that life is all rhythms, right? So they're biorhythms of vagal and sympathetic tone, right? So it also requires that at that moment, the biorhythms of vagal and sympathetic tone were such that the A and the B had that relationship, right? I mean, these are not fixed static things, right? This is the concept of an A and a B, but the A and the B can, they change minute to minute based on sympathetic and vagal influences, right? Right? Life is all rhythms, yeah? That make sense? Okay. So let's go 10 more minutes and we'll take a break, okay? Is that fair? Okay. Can you do that? Oh, you want to take a break now? You burnt? Let's stop? What? Push through, okay. 10 more minutes, okay. So let's say in muscle, atrium and ventricle. What drugs, what governs conduction? Remember, this is the upstroke. This is not relevant in atria or ventricle because the phase 4 automaticity is really only relevant to the sinus node. Once the atria and ventricles get their signals from above, what is relevant is their conduction, which is the upstroke. Right? The phase 4 is really relevant to generate the sinus node automaticity. Right? So what governs conduction in muscle, atrium and ventricle. What ion? Sodium. So if I want to block conduction in atria or ventricle, I need a sodium blocker. Right? So I'm going to need a drug that's going to act on the sodium channel. Right? I could kind of take a mild approach. What would a beta adrenergic blocker do? Well, we said beta blockers, we said the beta adrenergic tone facilitates sodium transport, so I could use a beta blocker. It might work, but it's not a very strong approach. Yeah? So a beta blocker might do a little thing. What governs the refractory period in ventricular muscle or atrial muscle? What ion governs the refractory period? Remember, if I sum up, well, what is the refractory period? What ion governs the refractory period? Potassium, right? Sodium's going in, and the thing that repolarizes the cell is potassium going out, right? If I